Okay. Another use of phentolamine is to reverse the extravasation of epinephrine, norepinephrine, or dopamine. So you remember when we're giving these drugs and that IV medication extravasates, which is leaking out of the vein to the surrounding tissue and causing something damaging, those medications can cause vasoconstriction. If we have vasoconstriction, we're not able to get blood to the surrounding tissue. And if it doesn't get blood for long enough, the tissue begins to die. So giving phentolamine is going to be a reversal agent. Why do you think it would be a reversal agent? So the epinephrine and norepinephrine could cause vasoconstriction, but we know our phentolamine causes vasodilation. So that's why it would be a reversal agent. It's reversing the effects because it's creating vasodilation. So phentolamine, we see our contraindications here. And I don't talk too much about interactions, but there are some interactions that are important. So those are the interactions I'll point out. So there is an interaction with phentolamine and ETOH, which is alcohol. So if somebody is taking phentolamine and they're drinking alcohol, they may get very sick. And what I mean by that is flushing, lots of nausea. This is called a disulfiram reaction. If you remember back in chapter 17, we talked about disulfiram. Another word for this medication is called antabuse. When somebody is taking disulfiram or antabuse and they drink alcohol, they become very sick. That disulfiram or antabuse is a deterrent for somebody who has alcoholism. Now, some medications we'll talk about have a disulfiram-like reaction. So it's kind of like the patient is taking disulfiram or antabuse. So when somebody is taking phentolamine and they drink alcohol, they have the same effect. They get profuse nausea, vomiting, and the flushing. Another medication that we can see an interaction with is erectile dysfunction medication. A big one we talk about is sildenafil, which is Viagra. If somebody is taking phentolamine and taking sildenafil, brand name Viagra, they can experience additive hypotension, decrease in blood pressure. Okay, so tamsulosin or Flomax is a medication we give most often for BPH, benign prostatic hyperplasia. Now this medication, if you remember BPH is that constriction, the prostate constricts around the urethra and the patient has a hard time urinating. The tamsulosin will relax those muscles and allow more urine to leave the body. Now, another indication would be patients with kidney stones. Kidney stones are little rocky stones within the urinary system, and they can be very challenging to pass, incredibly painful. So the tamsulosin can open up or dilate that urinary system and make the kidney stones easier to pass. Now again, when tamsulosin is taken with erectile dysfunction drugs like sildenafil, brand named Viagra, we can see additive hypotension. So again, just that picture about BPH to give you a visualization. Okay, so we're on to beta blockers. Before we start this portion, I want you to think, what did a beta-1 agonist do? So a beta-1 agonist. So If you remember, a beta-1 agonist had a positive inotropic effect, positive chronotropic effect, and positive dromotropic effect. So inotropic was increasing contraction, chronotropic was increasing heart rate, and dromotropic was increasing the electrical activity through the heart. So these beta blockers are going to do the opposite. So we're going to have a negative inotropic effect, which is decreasing the contraction of the heart muscle, negative chronotropic effect, which is decreasing the heart rate, and a negative dromotropic effect, which is decreasing the electrical activity. So when one of our beta blockers is a selective beta blocker, it's going to work specifically on the heart. Now we have some non-selective beta blockers. And remember, if something's non-selective, it works on more than one receptor. So these non-selective beta blockers work on beta 1 and beta 2. Now what was beta 2? What are our beta 2 agonists? Our beta 2 agonists work on the lungs. Remember, one heart, two lungs. So if I have a beta 2 agonist, I'm going to see bronchodilation. If I have a beta 2 antagonist, what am I going to see? Bronchoconstriction. So that means our airways are actually getting smaller, which is concerning. What condition do you think this would be the most concerning with? So what respiratory condition? You said asthma and COPD, you are absolutely correct. So if somebody is taking a non-selective beta blocker and they have COPD and asthma, we're very concerned. Somebody who has COPD and asthma should never take a non-selective beta blocker. The last name of beta blockers are LOL. So atenolol is a beta blocker. Metoprolol is a beta blocker. Propranolol is a beta blocker. You see where I'm going with that. So the last name is LOL. So we have a lot of different indications for beta blockers. They're good medications. So angina or chest pain, we can treat. We're going to get more blood flow through the heart. We're going to decrease the need for oxygen blood in the heart. Beta blockers, when given when somebody's having a myocardial infarction or a heart attack, actually decreases mortality. So if we give a beta blocker when somebody is having an MI, myocardial infarction, they're more likely to live. So that's pretty cool. Beta blockers can be used for cardiac dysrhythmias. A dysrhythmia is abnormal electricity firing in the heart. Hypertension, heart failure, migraines, and glaucoma. Now, we have some contraindications. If we think about what is happening in the heart when we give a beta 1 blocker, what is a negative inotropic effect? Decreasing contraction in the heart. Now, when I decrease contraction in the heart, my heart is not going to beat as strongly. Some conditions like uncompensated heart failure or cardiogenic shock, my heart is already beating less strong. So that would be concerning. Heart block, we already have less electrical activity in the heart with a heart block, so we would not want to see a negative dromotropic effect. Bradycardia, we would be concerned. That's a low heart rate. Because if somebody is having a low heart rate and we give a medication that has a negative chronotropic effect, we're going to decrease the heart rate even more. And then which receptor are we concerned about if somebody has COPD and asthma? Blockade at beta 2. Remember, if we're blocking beta 2 receptors, we're going to see bronchoconstriction. If we have bronchoconstriction, we are not going to breathe as well. Now, a little point at the bottom, which is a really big point, is that we never want to stop beta blockers abruptly. So that would be I'm taking beta blockers consistently for 5 years, and then I stop them right away. If I stop that abruptly, I can get rebound, so rebound coming back, hypertension, so my blood pressure could shoot up. I can actually have a myocardial infarction due to that withdrawal. So you'd be very concerned. So if somebody is stopping a beta blocker, they need to taper, which means slowly lowering the dose over 1 to 2 weeks.